Suwankomonkul. He's going to talk about the HTO in medial meniscus root tear, when and how. Please start.
Good morning, everyone. Thank you, Chairman, Co-Chairman. My name is Pattanapong Suwankomonkul from Pattaya Hospital. My talk is HTO in medial meniscus root tear, when and how. As we know the anatomy, so the posterior meniscus root is just about 10 millimeter behind the medial tibial eminence, and they have three zones, transition zone and mid-substance and axial zone. So the function, as you know, for the load transmission is convert the compression force to the hoof state and increase the contact surface for reduce the contact pressure, and 50 to 70% of the load transmitted by the medial meniscus, and also instability. For this study show the biomechanic, if our medial root meniscus torn is equal total meniscectomy. So what the sequelae of the chronic root tear? There we will have meniscus extrusion following with the loss of the hoof state, cartilage damage, and end up with the OA change. So the natural history, in case that unrepaired symptomatic, about 30% will proceed to the TK within 5 years, and about 66% in case that meniscectomy will progress to the OA, compared the root tear just 22%. So the lower study show the osteonecrosis of the knee is very high related with the root tear, about 50 to 100%. So the investigation, the interesting is a Rosenberg view. You can assess the medial joint space as well, and also you should do the scanogram for the whole leg. So the meniscus for the MI is a gold standard. That we know the typical, the classic, you see the cleft side in coronal and the growth side in sagittal, and also have a medial extrusion more than 3 millimeter. For the factor, for the effect of the outcome is many factors. Patient factor, alignment, good or not, cartilage, injury, damage level, aging, and meniscus factor is good quality, meniscus or not, extrusion a lot or not, technical demand, surgeon experience. But the important thing is about the timing. If you repair before 13 weeks, you will prevent the progression of the meniscus extrusion following this study. So what is the indication for the root repair? Acute traumatic root or chronic, you have symptomatic, but you make sure before the no OA or KL less than 2. Two studies show in the upper one is for the biomechanic. If you repair, you can restore the normal kinematic and contact pressure. The low one is a study show that if in repair group can provide the greatest improve of the function and lower risk of the convert to the TK compared to the conservative group or partial meniscectomy. So for the technique, as we know, we have two kinds of the technique: transtibial pull out or anchor suture. Transtibial pull out is good mechanical staying and don't need special equipment, but also they have some problem for the suture during you do the HTO, and sometimes the suture elongation or abrasion during you do it. For the anchor suture tight technique, okay, sometimes the knot on the top at the meniscus is really irritated to the cartilage. And sometimes if you use some technique like a soft anchor through the tunnel, the fixation of the knot maybe loose knot in the tunnel. Or some technique you need, most of technique you need to have a posterior portal also. And this study compare this paper show transtibial suture versus ankle, which one is better? Two studies show the ankle suture better. In the first study from the Munich by Professor Hope group, they show the biomechanic superior property than pull-out repair. So the lower one is show the ankle suture repair, superior healing and rhizome score. And also you can better tension adjustment during you tying knot. So sure, because the medial, if you have not space enough, you should MCL release. I use this technique 1.5 centimeter posterior and distal from the medial epicondyle. So what the contraindication in the box you see, if you have a narrow joint space, alignment not good, more than 5 degrees, BMI high, more than 30, the lag gap, 8 millimeters something, or extrusion more than 3, and subcondylar bone collapse. Okay, this one you cannot do repair alone, should not repair alone. Okay, so that means the 3 factors you should consider: alignment, good or not, cartilage damage, what the level of the cartilage damage, and ligament injury. You have any ligament reconstruction together or not? If you have a contraindication, such as the Wallace more than 5, you should combine with the HTO, or the gap is more than 6, you should do the reconstruction as the previous speaker talk. And the cartilage depend on the area of the cartilage problem. You should do microfracture or ACI. As the Dr. Koga lecture also, if the the extrusion more than 6 or 8, you need to do centralization. So this is my case. They have root torn and the extrusion a lot. I do the centralization and root repair. So how about the HTO? The principle of HTO is for the unload at the contact side, that means unload the medial to lateral for restore the medial cartilage and healing of the meniscus also. So sometimes you maybe have some indication overlapping between HTO and UKA, but UKA in kind of the cartilage problem a lot and low demand, you can choose the UKA. In the opposite side, if active and a lot of Wallace, you choose the HTO. So what the indication for the HTO in the root tear? Wallace more than 5, unequal medial joint space, extrusion more than 3, and sometimes you have also necrosis or have a subcondylar bone edema. So in this case, I performed many years ago. He have a root torn with the Wallace. I just do the HTO, and now he's quite good now. But another side, the cartilage is gone a lot. I perform TKA. So how about the open and closing weight? The open have many advantage, like you can accurate your correction and less soft tissue damage and less the peroneal nerve injury. And also you can prevent the proximal tibial fibular joint and less the opposite cortical bone fracture. So how much the angle you need to correct? So we don't have the ideal correction angle. It's still controversy. So some papers said about 8 to 10 in anatomical axis. Some studies show 0 to 6 is a vary. 0, 1, 2, 3, 4, 5, 6 depend. So in the lower table, they show what angulation that you correct will be fail. So if back canal axis less than 2 degree valgus, it should be fail. So this is a nice study from the Professor Imhoff in Munich. They summarize like cartilage damage at the medial compartment. If cartilage damage grade 1 or 2, you should to correct about 55 to 60%. If cartilage is damaged in grade 3, 4, you should correct a lot, depend on the percentage of the width of the plateau, like Fujisawa point. So how about the HTO and alone or HTO with root repair? So the studies show HTO alone is not too bad. The studies show the root HTO alone is not influence better than the root and HTO. So HTO is still work. How about HTO and root repair? One thing that advantage, you can get the root healing good and the cartilage have a good regeneration. So the low one is last year study that's confirmed that if in case that you have a HTO compare, you use HTO alone or repair. So what is the problem during you do the HTO and root together? So the main problem is tunnel is jamming. So if you choose the root repair first, and you choose the transtibial technique, so what would you should do? You should prevent, right? You should prevent your tunnel during your osteotomy or the screw jamming something. So you should put something in the tunnel. You should put a lemur or guide wire to protect it. And the second trick is for the entrance of the tibial position, you should more anteriorly, okay? Or the second choice, if you choose the transitional technique first, you can a little bit osteotomy cut lower and some design of the plate have a room enough for your make a tunnel. So if you choose the HTO first, I think this one is a very benefit. The first thing you can release the superficial MCL, right? You have a room set enough for you do the root repair later, okay? This video I try to demonstrate. And the second one is if you do the HTO first, you can choose the tunnel, what you want. Medial, basically medial, a little bit lateral, you can choose it. If your deal hit the screw, okay, you can change or you can remove the screw. Mostly the anterior screw will hit the tunnel. So I prefer you don't put the anterior screw and then you can put later. A little bit short screw is not problem. So ankle suture, this one is maybe is a very benefit. Okay, no tunnel jamming and not interfere the screw. And the elongation of the suture is not happen. So you can do the standard anterior portal and don't need to posterior portal. Okay, thank you.